A 38-year-old man presents to his primary care physician with a complaint of progressive weakness in his hands and feet. The patient states that these symptoms have slowly progressed over the past few months. Initially, he was unable to manipulate small objects, such as picking up a coin or buttoning his shirt. Now he complains of difficulty grasping a gallon of milk and notices the muscles in his hands twitching. He often trips while walking because he feels he cannot lift his toes up and lacks coordination. In addition, he says that the muscles in his leg occasionally cramp or spasm. What is the most likely diagnosis? Amyotrophic Lateral Sclerosis, ALS, or Lou Gehrig disease is a neurodegenerative disorder that causes progressive muscle weakness. It is associated with progressive destruction of the upper motor neurons in the cerebral cortex and lower motor neurons in the spinal cord and brainstem. Where are the lesions located, and how does this explain the hallmark findings? The hallmark of this disorder is the presence of both upper motor neuron and lower motor neuron lesions. Amyotrophic lateral sclerosis affects anterior horn motor neurons in the spinal cord, lower motor neurons, and the lateral corticospinal tracts carrying upper motor neurons from the cortex. Sensory and cognitive functions are generally preserved. How is this condition distinguished from the ascending paralysis syndromes? Amyotrophic lateral sclerosis has both upper motor neuron and lower motor neuron findings, whereas Guillain-Barré syndrome, or acute inflammatory demyelinating polyradiculoneuropathy, and chronic inflammatory demyelinating polyradiculoneuropathy, are solely lower motor neuron diseases and present with characteristic decreased reflex response. What distinguishes upper motor neuron signs from lower motor neuron signs? Upper motor neuron signs result from lesions that disrupt neurons or their pathways in the brain or spinal cord. Upper motor neuron signs include weakness, hyperreflexia, increased tone, positive Babinski sign, positive clasp knife spasticity, and no fasciculations. Lower motor neuron signs result from lesions that disrupt lower motor neurons in the spinal cord, ventral horn, or their peripheral axons. Lower motor neuron signs include weakness, muscle atrophy, decreased tone, hyporeflexia, muscle fasciculations, negative Babinski sign, negative clasp knife spasticity. What is the Babinski sign? The Babinski sign is obtained by taking the end of a Taylor reflex hammer or the fingernail and stroking the plantar surface of the foot. A positive sign is when the big toe extends upward, also called extensor response. A negative sign is when the big toe does not extend upward. It is normal for infants to have a positive Babinski sign until the age of 12 months, due to incomplete myelination of the corticospinal tract. What is clasp knife spasticity? Clasp knife spasticity is expressed by taking the patient's arm and passively flexing at the elbow joint. A positive result is when there is initial resistance by the extensor muscle to the passive flexion. As the arm is continued to be flexed, the extensor resistance gives way abruptly. The arm collapses, allowing the flexion of the limb to become easier. What is the course of this disease? Amyotrophic lateral sclerosis is currently an untreatable disease with progressive neurodegeneration and muscle weakness, resulting in death within 3 to 5 years of diagnosis. Riluzole can prolong survival by 2 to 3 months, likely by blocking glutaminergic transmission in the central nervous system. Supportive care, including dietary modification, respiratory assistance, and palliative care, is an important part of management. Neuromuscular respiratory failure is the primary cause of death,